Hello, and thank you so much for tuning into my channel, Your Time to Excel. My name is Alexandra, and I am the founder of Excel Healthcare Institute, and I am passionate about helping people pass the NCLEX, getting their license, and working in their dream career of being a nurse. I am going to be releasing content on YouTube and social media to help people to study for the NCLEX and to pass. So if you haven't already, please like this video and subscribe to my channel so that every time I put out a new video about the NCLEX that can help you pass, NCLEX tips, NCLEX secrets, that you get notified when that video gets released. Today, we're going to be talking about fetal heart rate patterns and whether they are reassuring or non-reassuring. Reassuring is good. We don't have to do anything. We're just going to continue monitoring mommy and monitoring baby. Non-reassuring fetal heart rate patterns are not good, and we need to know how to recognize them. We need to know the interventions to take so that we can take good care of mommy and baby. All right, so without further ado, let's go ahead and get started. So there are two ways that we can monitor a fetal heart rate. We can do it externally, where mommy has two bands. One band has a sensor on it that is monitoring mommy's contractions. And with contractions, we want to monitor how strong they are, how far apart they are, and how long they last. One thing you need to know for the NCLEX is if mommy's contractions are too strong, if they're too close together, or if they last too long, that will put too much stress on the baby. Because when mommy has a contraction, the baby does not get any oxygen, because when mommy has a contraction, the uterus is going like this, and it's literally closing off the blood vessels that give baby oxygen. So if it's squeezing too hard, or they're squeezing too close together, like here's a contraction and then the next one comes too closely, or when mommy does have a contraction, it lasts too long, baby is going too long without oxygen. Okay, so we're monitoring mommy's contractions. The second belt has a sensor that is monitoring baby's heart rate. So that's external, where you have the two bands. Internal is when you have an intrauterine catheter inside the uterus. Okay, so this is a fetal heart rate strip. So there's two parts to it. The first part, this is the baby's heart rate or the fetal heart rate. And this is mommy. These are mommy's contractions. So whenever you see it go up like a hill, those are mommy's contractions. So let's look at the fetal heart rate. We see that it goes as high as 150, even a little higher towards the end. And then the lowest that it dips to is about like between 100 and 110. All right, so you always want to see how high does it go, how low does it go. And keeping in mind that a normal fetal heart rate is between 110 and 160. So that means if the baby's heart rate drops to as low as 110 and goes as high as 160, that is okay. If it stays in between those, that is okay. Okay. The next thing we're going to talk about is the baseline. And the baseline is where the fetal heart rate tends to stay for most of the time. In this case, it's safe to say that most of the time, the baby's fetal heart rate is about at 150, which we can see by drawing a line. Okay? So about 150. All right, so the first thing we're going to talk about is how we're going to set up our little study, our little study aid, our little study guide for this. So I divided it into 3 sections: reassuring, which is good; non-reassuring, which is bad; and no intervention needed. If you're taking notes, you can take notes. You can write this down at the very end, or you can go along with me. But at the very end, all the fetal heart rates will be there and divided into their appropriate category. So the first two we're going to add is fetal bradycardia, which is when the fetal heart rate drops and stays below 110, and fetal tachycardia, when the heart rate rises to and stays above 160. Both indicate some type of stress and are non-reassuring, and we have to step in, identify the cause, and fix it for the sake of the baby and mommy. Next, we're going to talk about variability. So variability is the fluctuation. So fluctuation is up and down, up and down. Fetal heart rate variability is a good thing. We want to see variability. The way that I remember it is variety is the spice of life. So it's just going to be really boring if your life is just like a flat line. But if you have lots of movement in your life is going to be fun. It's going to be good. That's how I remember it. Variety is the spice of life. So when you have fetal heart rate, the first box we see absent. That is not good. There is no variability. Absent variability. Minimal variability. It's obviously better than absent, but still not too hot. Moderate and marked fetal heart variability are very good things. Okay, this next slide is going to show you again absent, not really any fluctuation. Moderate, we have some. Marked, excellent. We've got ups and downs. All right, in short, decreased or absent variability is non-reassuring. It's not okay, and it indicates fetal hypoxia, baby's not getting enough oxygen, acidosis, certain medications can cause it, and baby may be sleeping. But these sleep episodes won't last more than 30 minutes. So in the reassuring or good section, I put variability. If variability is present, preferably marked, moderate and marked, yes, we're doing good. Non-reassuring, fetal bradycardia, fetal tachycardia, and variability that is decreased or absent, not a good thing. Fetal heart rate accelerations. So as you can see, every time the fetal heart rate goes up above the baseline by 15 beats for at least 15 seconds, this is reassuring. It's good. It shows that the baby is responsive, okay? And that the baby is non-acidotic, because we do not want a fetus that is acidotic, okay? Accelerations could be due to fetal movement. As baby moves, he's moving, his heart rate goes up. No problem. All right? There's nothing wrong with this. As long as it doesn't go into fetal tachycardia above 160, we're doing fine. Or as long as it doesn't stay above 160, we're doing fine. And fetal heart rate accelerations don't necessarily occur with a contraction, which means if mommy has a contraction, it doesn't mean that baby's going to have a fetal heart rate acceleration. So I put accelerations in the good column or the reassuring column. Early decelerations. Early decelerations are when the fetal heart rate drops when mommy has a contraction. Okay? So early decelerations are decreases in the fetal heart rate below the fetal heart rate baseline. These occur simultaneously at the same time with a contraction. What could be happening is that every time mommy has a contraction, the baby's head is pressing against mommy's cervix. All right? By the end of the contraction, the fetal heart rate returns to normal. So I'm going to show you something. So as we can see, this is a contraction. This is a contraction. This is a contraction. So this is mommy's contractions. This is the fetal heart rate up here. So every time mommy has a contraction, the baby heart rate drops below baseline because the baseline is where the baby's heart rate tends to stay. Okay, so this dip with the contraction, the baby heart rate dips or decelerates. Here's another contraction, the baby's heart rate decelerates. So an early deceleration happens at the same time as mommy has a contraction, and it goes back to normal when the contraction is over. So for early decelerations, no intervention is needed. There's nothing wrong with it. Late decelerations. Late decelerations, they came late to the party. You have decelerations when you're driving a car and you decelerate, you slow down, you go down. Decelerations are still happening, but they're late. They come after the contraction is already over. So it's like you take an early deceleration and you just slide it over, okay? So remember, early decelerations, the heart rate drops exactly with with mommy's contractions. Late decelerations come after the contraction is over, so that's why they're called late. All right, they're late to the party. So late decels, decreases in the fetal heart rate below the fetal heart rate baseline. The deceleration occurs after a contraction. Let's draw an O. Just pretend I had a space and an O there. So the deceleration occurs after a contraction. And what is causing this is called uteroplacental insufficiency. So anytime you see a big word, try to break it up into the individual words and it will tell you. So when something is, what does it mean when you go to the bank and it says you have insufficient funds? You don't have enough. Utero, placental, uterus, placenta. The placenta is not giving the uterus enough oxygen. All right. The uterus is like, I need some oxygen. And the placenta is like, insufficient funds, no overdraft fees. Peace out. Okay. So you're having late decelerations because the uterus is not getting enough oxygen from the placenta. Your goal should be to improve placental blood flow. So as we improve blood flow to the placenta, we're going to increase fetal oxygenation because oxygen will be in that blood. Okay. So this is a picture of a baby, a cute little baby in mommy's uterus, and then we see the placenta and we have a close-up of the placenta. And so this is just to show you, remember, in your umbilical cord, it's AVA. You have two arteries and one vein, AVA. So it's just to show you the blood supply coming from the placenta. And here, I'll show you with the spotlight. So this is this is the placenta, and this is the blood flow that the placenta will give straight to the baby's umbilical cord, okay? Now, when a mother has placental insufficiency, there is a lack of adequate blood flow to the baby, which can cause the baby to have intrauterine growth restriction, oligohydramnios, which is when they have low amniotic fluid, and nutrient and oxygen deprivation. So whenever we have poor blood flow to the placenta, we are going to have poor oxygen and nutrients being delivered to the uterus and to baby, okay? When this occurs during contractions, labor and delivery, the baby's brain can suffer brain damage. Okay, cerebral palsy and seizures. So we're going to put late decelerations in the non-reassuring column. Next up, prolonged decelerations. Oh my gosh, That deceleration is going on forever. Remember, even in the early decelerations and late decelerations, it came down and came right back up. This one at the top, this fetal heart rate keeps decelerating, it keeps dropping as low as just above 30. So let's just call it 50 to as low as 50. And remember, a normal fetal heart rate is 110 to 160. This is no good. So we're going to put prolonged decelerations. Variable decelerations. Wow. So let's take a look at this one. So whenever you're looking at a fetal heart rate, look at the relationship between mommy's contraction and when the heart rate drops. Okay, that can tell you something. So let's get the spotlight and let's see. So here's mommy's contraction, and here we have some deceleration. Okay, there's no contraction right here, and yet we have some decelerations. There's a contraction here, no deceleration. No contraction, deceleration. So there's no uniform pattern. That's the first thing, because if we saw a mommy contraction and then we saw a deceleration, we would say that's an early deceleration. No problem with that, right? No intervention needed. If we saw mommy's contraction and then after the contraction was over, we saw a deceleration, then we would say that is a late deceleration. And we just learned that that's because of uteroplacental insufficiency. But this one has no pattern. This is called variable deceleration, because variable means variety, but don't confuse this with variability. So I want you to write this down. Variability and variable decelerations are not the same thing. We want variability. We do not want variable decelerations. Variable decelerations do not have the same pattern as early or late deceleration. Significant when the fetal heart rate drops below 70 beats per minute and lasts for 60 seconds. The cause of variable decelerations is cord compression. All right, so the way that I remember it is variable decelerations. You have decelerations, but they have no pattern. They vary when they happen. Sometimes they happen with a contraction, like the first one. Sometimes they happen after a contraction, like the second deceleration. I'm talking about the bottom where it says variable deceleration. So it's because the cord is being compressed, not good. If the patient is, if mommy is receiving oxytocin or pitocin, or as the seasoned OB nurses will say, PIT, okay? If they're getting oxytocin or pitocin, you need to stop it. Change mommy's position, because that will increase blood flow, increase oxygenation, give oxygen, and check mommy's vital signs. All right. We may have to put some warm saline into the uterus to relieve the cord compression, to lift that cord off. So in the first picture, we have a cute baby. There we see his umbilical cord. It's wrapped around a few times, but no big deal because it is open and we can see Ava. We can see two arteries and a vein. And remember, the arteries carry the deoxygenated blood and the vein carries the oxygenated blood. In the umbilical cord, it's the opposite, okay? So umbilical cord, write down umbilical cord equals Ava. Two arteries and one vein. The arteries carry deoxygenated blood and CO2, and the vein carries oxygenated blood, all right? So in the first picture, we have a normal situation. No compression of the cord. In the second picture, we see the cord is wrapped around the baby's neck. This will cause cord compression because somewhere along the line, somewhere where the baby's neck is going to pinch that cord. And that means oxygen can't get in, CO2 can't get out. we're going to end up with a hypoxic, acidotic, because CO2 is an acid. We're going to end up with a hypoxic because oxygen can't get in, acidotic because CO2 can't get out fetus. And as you can see, it's affecting the baby because the poor baby's blue. All right. So this is another picture on the bottom of umbilical cord compression. As we can see, the baby's head this time is pressing or compressing the cord. That is also going to lead to variable decelerations. In the picture at the top, and I'll show you with the spotlight here, the baby cord is being compressed. And as we can see, he's getting less oxygen than the first baby. First baby's getting all this nice oxygen. This baby, not so much, okay? Cord compression will decrease how much oxygen gets in. So we're going to add variable decelerations to the non-reassuring side. Now we're going to talk about normal, hypotonic, and hypertonic contractions. Normal contractions have a nice bell shape. They go up, go back down when they're done. Hypotonic, it's going to have the same shape, but it's going to be on a smaller scale, a weak contraction. And we need good, strong contractions, but not too strong, but we need good normal force contractions to help remove baby from the uterus, right? Hypertonic, they're either too strong or too much, too fast, okay? And remember I told you that every time the uterus contracts, it stresses the baby in a way because the baby is not getting oxygen. So I want you to write that down. Every time mommy has a contraction, the baby doesn't get any oxygen. So if the contractions are too strong, all right, that is not good. If the contractions come too close together, baby doesn't have time to recover and get oxygen, and the uterus doesn't have time to recover either, because every time it contracts, it needs time to relax so that oxygen can fill up and get to the baby. But if it keeps contracting, it will never have enough time to let enough oxygen get to the baby, okay? And also if the contractions last too long, all right? When it does relax, it's not enough time for baby to get enough oxygen. So we're going to add hypertonic uterine activity to non-reassuring, because hyper means too much. Tonic, I think of muscle tone. So hypertonic, the muscle of the uterus is contracting too strong or too much, okay? If a non-reassuring fetal heart rate pattern is noted, you need to stay with the client, identify the cause, and we're going to talk about that. If the patient is on oxytocin and you see a non-reassuring fetal heart rate pattern, you need to DC or discontinue the oxytocin. Change mommy's position. Left is best to increase fetal oxygenation, because if you put her on her left, you're giving the placenta more blood flow. More blood flow to the placenta, more oxygen to the baby. You can write that down. You're going to give oxygen at 8 to 10 liters per minute via a face mask. If it is not contraindicated, prepare to initiate continuous electronic fetal monitoring. Prepare mommy for a C-section. Document the event, which is non-reassuring fetal heart rate pattern. Let's just say you saw late decelerations, your interventions, and the response. So NCLEX tricks and to fetal heart rate patterns and interventions. So this is a little tip on how you can know what to do when you have certain fetal heart rate patterns. So first you're going to write down veal in a row, just like how it is. You're going to write down chop, and then you're going to write down mine. So in 3 rows, 1 row veal, chop, mine. That veal chop is mine, honey. So VIL, variable deceleration. For variable deceleration, the cause is cord compression, and you need to move mommy on her left side. Early deceleration is because of head compression. Remember, every time mommy has a contraction, baby's head presses against the cervix, the heart rate drops during the contraction, comes back up when the contraction's over. I'm okay. Don't worry, it's all good. No intervention needed. Accelerations are okay. You don't need to do anything. Late decelerations are due to uteroplacental or due to placental insufficiency, and prepare mommy for emergency delivery. Okay. So that is it for our little video and discussion on fetal heart rate patterns and whether they are reassuring or non-reassuring. If you would like, for me to talk about a certain topic or certain question, I would love to make a video for you on it. So just leave a comment below on something that you would like me to make a video about, on something that you would like me to find some NCLEX questions about or NCLEX practice questions about, and we can go ahead and discuss it in a video. Thank you so much for taking the time to watch this video. I hope that it helped you. I hope it wasn't too long or too boring. I know I like to talk a lot, but what I did want to say is if you or anyone you know needs help passing the NCLEX, please let them know that Excel Healthcare Institute is here to help. You can go to my website, www.yourtimetoexcel.com. I'm going to put it in the description. You can call us at 407-907-3737 or 1-888-73-EXCEL. And we have NCLEX boot camps. We have NCLEX 3-month reviews. We have our own NCLEX study guide. We also do LPN program, CNA prep, and phlebotomy prep. So Excel Healthcare Institute is here to help you excel, to get your licenses, to get your certifications, and to get on your way to the career of your dreams in healthcare. Thank you so much. Please don't forget to like and subscribe. God bless you. Take care.